Sir, am I audible? Sir,
Yes,
am
you're
I?
audible.
Yes, so I'll go ahead, sir. Good afternoon, everyone. So today I am presenting about a 2-year-old baby boy who was absolutely well until 1.5 years of age with normal growth and development and no history of recurrent infections, TB contact, or trauma in the past. 6 months back, he presented with fever, fast breathing, and cough. He was taken to a local hospital for the same, where he was detected to have a tamponade. He underwent pericardiocentesis and empirically he was started on antitubercular medications. Despite good compliance, his symptoms persisted and pericardial effusion recollected. Hence, he was brought to us. When he presented to us, he was tachycardic, tachypneic, he had severe chest retractions, and on examination, his heart sounds were muffled and had significant cardiomegaly. On general survey, the skin was normal and there was no musculoskeletal anomaly. His chest X-ray at admission showed a massive cardiomegaly. However, there was no pleural effusion detected. When we did an echo, it was showing a massive pericardial effusion, which had to be drained on emergency basis, and an pigtail was left in situ. Now, this was the milky surprise that we received. It was a thick, tenacious fluid, and we at first go, it appeared to be like chyle. But could it be pseudochyle or could it be pericardium? The pericardial fluid analysis showed an elevated cell count with 90% lymphocytes, an elevated protein but normal glucose, and negative for evidence of TB or any bacterial infection. However, the lipids were highly elevated, confirming the diagnosis of chylopericardium. His baseline investigation showed normal blood counts, no evidence of any inflammation, normal serum lipids, and normal organ functions. So, considering the differentials of chylopericardium in a young child, the more common secondary causes were ruled out based on our initial investigations and evaluation. And hence, we were now left with primary congenital lymphatic anomalies. So, we went ahead with our definitive investigation after discussion with our radiology team. And we did an MR lymphangiography, which was showing absence of thoracic duct after the T5 level, along with a diffuse enhancement in the upper mediastinum encasing the great vessels and the airways and extending into the adjacent tissues. So, a lymphangiomatosis with diffuse proliferation of lymphatic tissue was our finding. We did a general survey which was showing no osteolytic lesions. So lymphangiomatosis can be of several types. In our case, Gorham-Stout disease and general lymphatic anomaly were less likely since there was no other systemic anomaly. And Kaposiform lymphangiomatosis is an aggressive form of disease, hence this was not the case. So we considered our diagnosis to be a central conducting lymphatic anomaly, which especially involves the thoracic duct. Now, by now, we had started the child on low-fat, medium-chain triglyceride-rich diet. However, there was only partial response. A surgical excision could not be done because of diffuse margins of the mass. We could not do an endovascular intervention because there was no specific leak site. Hence, the only option which we were remaining was drug therapy. We started him on sirolimus, which is an mTOR inhibitor. After we started sirolimus, there was a dramatic resolution of pericardial effusion and symptom resolution was also present, and he was discharged on day 24 of hospitalization. We followed up the child diligently in the OPD and maintained the sirolimus target level in the recommended range. And even after 5 months of therapy, he remained in remission. And this is his echo at review, which is showing only minimal pericardial effusion. We also repeated an MR lymphangiography, which was showing that the mass had completely vanished with only minimal enhancement around the left bronchus, as we see here. And the ultimate physician's reward is a happy child. The child is currently gaining weight, and we have planned a long-term sirolimus therapy for him. Now, chylopericardium can be diagnosed with good sensitivity and specificity based on a thick, milky yellowish fluid, an elevated triglyceride level, a total cholesterol to triglyceride ratio less than 1 with no evidence of bacterial infection. However, pseudochyle is a close differential, which is a complication of long chronic exudative pericarditis enriched with cholesterol over time. And in that case, total cholesterol to triglyceride ratio would be more than 1, TB and rheumatoid arthritis being the most common causes. Now, sirolimus is the agent that made the difference in this particular case. Sirolimus is an mTOR inhibitor. mTOR is a protein kinase enzyme that plays a key role in cell growth, angiogenesis, and lymphatic proliferation. Sirolimus inhibits mTOR and hence inhibits lymphatic proliferation. Now, the use of sirolimus in lymphatic malformations is relatively recent. This is a series of about 71 patients where sirolimus was used, and at least partial response was seen in most of the patients in this particular series. The most common adverse effects to be looked for are bone marrow suppression and increase in triglyceride and cholesterol level. Use of sirolimus in a young child should be done with caution. FDA has approved it for use in children only more than 13 years of age, that too in renal transplant. As of now, we do not know the duration of therapy and the safety in neonates and small children, whether it has any effect on growth and development, and especially what is the optimal dose in case of lymphatic malformations. Hence, I would like to conclude saying that this case demonstrates a rare clinical entity of chylopericardium presenting at a very young age, caused by a rare complex lymphatic anomaly, which we treated successfully with an off-label sirolimus therapy. Thank you.